Good afternoon, everybody. My name is Katie Cook. I am the Telehealth Project Manager for Adirondack Health Institute, and I'd like to welcome you to today's New York State Telehealth Learning Collaborative, hosted by the North Country Telehealth Partnership. This is our first meeting of the new year, so thank you to all of you who registered and have taken the time to join us today. We have some exciting updates later in the hour, as well as a great presentation from some folks at the Care Compass Network. So hopefully you can stick around for the whole hour to hear everything we have planned on our agenda today. So to kick things off, I would want to dive right into our presentation. This presentation is from the Care Compass Network, and they are going to speak to how a performing provider system helped a numerous amount of providers and community-based organizations to survive the COVID-19 lockdown. And specific to that, how telehealth was a huge component of that. So with us today, we have Dr. Wayne Terrace, who is the Chief Medical Officer of Care Compass Network, which is in Binghamton, New York. He was a physician advisor and chief medical information officer at Ascension Lourdes Hospital prior to joining Care Compass Network. And his prior clinical experience includes 32 years as a family physician in the U.S. Air Force and with UHS Medical Group in Binghamton, New York. Jim Rott is the Telehealth Program Manager at Care Compass Network, where he is responsible for successfully rolling out a variety of telehealth initiatives in the 9-county region, New York Southern Tier. He has worked in the IT field for over 28 years in a number of different industries and roles. He is a native of the Scranton, Pennsylvania area, where he earned his bachelor's degree from the University of Scranton. I'd love to turn it over now to the team at Care Compass Network. So Dr. Terrace, you can take it away.
Thank you so much, Katie, for the great introduction. And we're really happy to be able to be here today to present a program that has been very successful, we're excited about. I did want to briefly level set and just talk to the group about who we are, because I imagine not everybody is familiar with the district program. So Care Compass Network is a community nonprofit that was originally funded by the New York State District Program, which actually went from about 2015 through 2020. And we represent about 1/8 of the geography of New York State, as you can see depicted in the map here. And early on, we were divided up into 4 regional units, regional performing units, RPUs, just because we have some areas that are a little more urban, such as Binghamton and Ithaca, but by and large, this is really a rural PPS. But this division into these regional performing units allowed us to really execute our projects at a much more localized and appropriate level. Our region includes about 700,000 lives, including 200,000 Medicaid members. And we do partner with over 160 organizations. So even though DSRIP is really technically over and has sunsetted last year, we are continuing as an organization. We have both sustainability funds to carry forward our projects and programs, and we're in the process of evaluating those projects and programs to see what we feel is best to invest in at this time. But we do have a mission and a Vision 2025, and I just want to go through these quickly because this really speaks to why we initiated the CTAP program in the first place. So our mission is to improve the health and well-being of the community members in the CCN service area by supporting the development of enduring partnerships of clinical and community providers and empowering those partnerships to flourish in a value-based payment environment. And we do have a Vision 2025. We have planned to persist as an organization. Like I said, we have sustainability funds, but we are also developing other service lines and income streams. So we envision a care delivery environment that's more collaborative and better structured to deliver services that are integrated and coordinated around a person's need, We're a convener of stakeholders, a provider of services for network formation and operation, and a catalyst for innovation. And we are committed to service delivery that does improve the health and well-being of our communities. And I want to take this opportunity very briefly, speaking of the fact that now we're looking at grants and other revenue streams. A little bit hot off the press, but we have partnered with Ascension Lourdes, and we've secured a Cabrini Foundation grant to help develop and deploy telehealth training for the Ogdensburg Diocese. And this is quite large, including Clinton, Essex, Franklin, Jefferson, Lewis, St. Lawrence, and the northern portions of Herkimer and Hamilton counties. So the reason I bring this up is beginning late in January and early February, Care Compass Network will be reaching out to some of you, reaching out to entities in the region to provide input and advise us on content development and methods and modes of distribution. So this sort of thing is new to us and very exciting. Care Compass Network consists of a number of different divisions. Of course, I've highlighted IT since telehealth is what we're here to primarily talk about today. But we have very active operations, project management, finance, compliance, and new to us over the last year is our grants manager moving forward, and also a very robust population health analytics department. You can see here that, our IT strategy really, telehealth is the apex of the pyramid. So early on, you can see from bottom to top, this kind of represents the maturity of value-based care, which was just about at a zero when we started. So initially, we just wanted to make sure everybody had EMR, RIO connectivity, and then we have since stood up population health and care management platforms. And finally, as you can see here, that our telehealth program is really the apex of the pyramid. This is a fun little slide. I like looking at historical things, but I get a kick out of this. This on the left side, radio news, 1924, they talk about the radio doctor. And boy, if this isn't telehealth predicted, I don't know what is. You got the little guy opening his mouth and the doc on the other end checking his throat. And then on the right side, we've got diagnosis by radio, where the doc is actually using a device to, I think he's doing an examination. I hope he's not doing surgery, but this is something that's been thought about really for a century, and the future is certainly now. I did also, Jim's going to dive deeply into the COVID assistance program, but I just want to give you some examples of our telehealth initiatives. I think it's important to understand. Our big one was the skilled nursing facility medical and behavioral health consults, and this was developed over a period of probably 2 years, and we all realize that there are a couple things that are unique to the skilled nursing facilities. Certainly, off-hours medical support, as well as behavioral health provider support, is sorely lacking in a lot of these facilities. So we initially piloted this program with 6 partners, and it's been tremendously successful. The outcomes have been great. We've actually, on the medical side, avoided transport to the ED in about 25 to 28 or 29% of the cases, which is tremendous. And since then, we've expanded this to 12 skilled nursing facility partners. I also want to point out that while these programs are not technically part of the CTAP initiative, you can imagine how important they are. You can imagine how important it was for the skilled nursing facilities to avoid at all costs having to send their residents to the hospital in the midst of COVID. So this was used very extensively, and it was fortunate that we had stood this up. Other examples, Gerald's Pharmacy is implementing a telemonitoring project for respiratory patients to connect with providers, receive care at home, and their outcomes have been tremendous as well. Tioga County Mental Hygiene had implemented an e-visit project to provide behavioral health services to rural patients because of transportation and childcare challenges. And again, this was stood up just prior to the onset of COVID, and you can imagine how successful and useful this was to have the tele up and running in the midst of the pandemic. And finally, a different population, Springbrook, New York, is implementing a variant of this where they're using pre-existing portable equipment to serve the IDD population in a number of group homes, as their staffing certainly wouldn't allow, for example, a nurse to be present at each home at any given time. So these are just examples of the projects. And finally, COVID-19 response. So I mentioned the skilled nursing facility programs, which went through a painstaking process over years to develop use cases and finance and take it to the various committees and the board of directors. But what happened last March? Well, COVID, and February and March. And in mid-March, we really conceived this program, and we were kind of proud that we had the agility to turn this over quickly. So it was conceived in mid-March and open to receive applications on April 3rd. And we had 2 rounds of applications, which Jim will elaborate on. And then the final application period closed on May 8th. So we turned around a very extensive program, literally in a month and a half. So with that, I'm going to turn it over to Jim to elaborate on more details of the CTAP program.
Okay, thank you, Dr. Terrace. As Dr. Terrace alluded to, I'm going to go into a bit more detail about this program and its features. This slide gives an overview of the CTAP and how it was structured. And first off, I want to clarify, this program was intended for non-hospital, independent primary care providers and community-based organizations. And that was done primarily because these types of entities typically have less resources than a hospital or a health system to respond to a situation like the pandemic and the lockdown. And we wanted to make sure that we could provide assistance to organizations that might have otherwise been forgotten about or lost in the shuffle amid all the chaos surrounding the pandemic. Early on, there was a lot of attention on hospitals and health systems by both the media and various government agencies. And it seemed that no one was looking at how it was affecting smaller organizations that also play a key role in the healthcare system. So our goal was to have a significant impact and assist as many independent organizations in the Southern Tier as possible. The program was designed to cover not only equipment costs and fees, but also any recurring service fees for platforms like Zoom or Doxy for up to 1 year of service. It was intended to help organizations get through the lockdown and beyond. The hope being later things would be looking brighter and the worst would be behind us. So, but now here we are 10 months after the launch of the program, and it seems like we're still in the thick of things regarding the pandemic. I guess, however, the fact that we've got vaccines and we're starting to get those out to more and more people does give us some hope that we're in the home stretch of this crisis. The program provided a maximum of $50,000 per awardee, and interestingly enough, only 3 applicants sought and were awarded the maximum amount. The other 31 applications were all over the map, dollar-wise, the lowest being in the $2,000 range. We had a few that were down at the low end. As I mentioned, we had a few that were at the high end, and the rest fell everywhere in between. Also, these funds were based on actual invoices, and it wasn't just a lump sum grant where we awarded a dollar amount and then just sent a check for that amount out to the applicant. This is a reimbursement model. We did require quotes up front so that we would have a relatively accurate estimate to include in the partner's contract, but the funds were ultimately paid out against actual vendor invoices. This program was not meant to provide funds for anything that the partner was to receive funds for elsewhere. Remember, our goal was to stretch our funds to assist as many organizations as possible. So if someone was receiving other assistance for a telehealth initiative, we didn't want to double fund one organization while another organization might be left with nothing. So we put that criteria right into the application process. All of the applications that we received were ranked using a rubric. We developed a scoring rubric based on a number of criteria. These included things such as demonstration of need, number of Medicaid lives served, and a few others. This was done in the event that if we had too many applications to fund, we would need a way to rank them so that we could defend our decisions on why one partner might receive funding while another one would not. Fortunately, it didn't come to this, and we were able to award all 34 applicants the full amount that was requested. Now, also, as Dr. Terrace had mentioned, one of the most important features of the program was the rapid turnaround time. Due to the urgent nature of the situation and the fact that many of these organizations were really hurting, we wanted to make the process as streamlined and efficient as possible in order to keep those partners operating and serving their patients and clients. And as you saw on that slide, we achieved this goal by taking the program from concept to awarding 34 partners in less than 8 weeks, which we felt was a pretty good turnaround time for this type of program. Now on this slide, we have an overview of the CTAP by the numbers. Although we had originally budgeted $750,000 for this program, and initial maximum contract amounts were in excess of that, we ultimately paid out significantly less dollars than expected, and we came in under budget. I think this is primarily due to the fact that we were paying out based on actual invoices incurred and not just handing out cash to be spent at the partner's discretion. Our finance department is very meticulous when it comes to documentation, and they made sure that every penny had to be accounted for. Also, we have the by organization type. You may notice that the number of organizations on the left adds up to more than 34. This is due to the fact that we allowed the applicants to identify as more than one type, and several of them did so. And you could also see by this graphic that mental health providers and social organizations made up the vast majority of our funding recipients. Next slide. Now this graph shows the breakdown of telehealth platforms that the participating partners selected, with Zoom being the most popular choice, which is probably reflective of the health industry at large. The main reason I included this slide is not the vendors, but to talk a little bit about how we have worked to add value to the program. When some partners first applied for this funding, they were in pretty dire circumstances. Their regular operations were shut down due to COVID. They knew they had to do something to try and function remotely, but some of them had no idea where to begin or even which questions they should be asking. So I spoke with each one of these partners individually, and I asked them what are the problems that we're trying to solve to try to get a handle on how the pandemic and the lockdown was affecting their particular organization. And we would go from there to help guide these partners who were at a loss in order to recommend solutions, to share what other partners had learned and how that worked. We didn't see our role just as the bank handing out money, because if an organization has no idea where to begin, then you can hand them all the money in the world and it's not really going to make any difference. We saw ourselves as a technical resource, providing information and guidance to help them navigate a very difficult situation. This is where CCN really added value to this whole process and helped to ensure the success of the program. Next slide. Now on this slide, of actual verbiage that's taken from CTAP applications. This illustrates the broad range of challenges faced by different organizations and the impact that the lockdown was having on the vulnerable populations that they serve. This first example highlights another side effect from the lockdown, where some students receive counseling or behavioral health services through school. And when the schools closed, this put yet another burden on the primary care providers and the behavioral health providers in the region to sort of fill in that gap that was left by the schools being closed. Now, these other examples also highlight how many individuals who were receiving services from these organizations had those services suddenly stopped as a result of the lockdown, with virtually no notice and with no alternative plans in place. These were exactly the kinds of organizations that we were targeting and exactly the kinds of problems that we were trying to solve. The lockdown was effective at slowing the spread of COVID, but the price that was paid was an exacerbation of many of the other medical, behavioral health, and social ailments in the region. And this is where the CTAP really came in, to provide relief to the organizations in the southern tier who were battling these ailments and were being forced to kind of take up the slack, as mentioned in that first example, when the schools closed. Next slide. All right, now I've talked a lot about what we were trying to achieve with this program and what our goals were and the problems we were trying to solve. These next few slides take a look at how we did and if we accomplished our mission. We feel the best way to gauge the success of a program is by talking to the partners who were on the front lines using the program and see how it worked for them and how they felt about it. So with that in mind, we just recently sent out a survey to all of our partners who participated in the CTAP to get their thoughts on the program and its impact. We can see here by this graph that 39% of those surveyed felt that this program was absolutely critical to their organization's survival during the lockdown, with another 33% saying it was very important to their organization. The remaining 28% felt that it was a helpful supplement to what they were already doing. Now, there was a fourth option on the survey that stated that the program was of minor importance to their organization. And as we can see here, no one selected that option. So all the participants found the program at least helpful, and 39%, which would translate to about 13 organizations, felt that they may not have survived without it. And that's a pretty significant number. It's scary to think that the pandemic could have permanently shut down 13 organizations that serve the people of the southern tier had it not been for the CTAP program and the assistance provided by Care Compass Network. Now, these numbers alone would have many people considering this program a smashing success, but I think that the real success of the program is measured by the actual results on the ground, the direct positive impact that it had on many lives in the region, which will bring us to our next couple slides. Now, these next two slides have actual success stories from the partners who participated in the CTAP, and this illustrates the real impact on people's lives that I was referring to. The Family Services of Chemung County told us that there were so many clients suffering from loneliness and staying connected to a mental health provider during the pandemic and lockdowns was very essential for these folks. This highlights how those already battling mental illness were basically hit with a double whammy from the lockdown. They had to deal with the isolation and the disruption of their usual routine, and they were cut off from their regular mental health providers. Dryden Family Medicine told us that one of the significant impacts is that they were able to contact patients who do not have a voicemail set up or who have a full voicemail to remind them of upcoming appointments or let them know they have a message for them, and basically communicating with them via text or chat message. And this primary care provider learned something that those of us who have teenagers already know, is that nobody answers their cell phone or makes calls with their cell phone anymore. Everything is texting and various chat and messaging applications. This practice was able to upgrade their systems so that they could directly send text messages and chat messages to their patients and greatly improve communications with them during the lockdown. Next slide. The Chenango Health Network was running a breast cancer support group that was forced to stop meeting last March, and the group facilitator was able to transfer those meetings to virtual online meetings via Zoom in order to continue to facilitate these important connections and support. This is another example of something that many people hadn't considered before the shutdowns. What happens to all of the support groups who have been meeting in person for everything from cancer to depression and anxiety to substance use disorders? Suddenly you had these groups were completely shut down, leaving thousands of people without a critical lifeline that they may have been depending on for years. So this program was able to provide that lifeline via a telehealth alternative. And finally, one of the most poignant examples that I heard was from Rural Health Network of South Central New York, where they had a client who was struggling with depression and anxiety for some time. That client was provided a tablet in July as a way to reach her therapist via telehealth. And this client had mentioned numerous times that she would not still be here if it were not for the accessibility we had made possible for her. So here we have a woman who is stating unequivocally that access to telehealth services during this time literally saved her life. There's really not much more you could say about that. I think that really speaks volumes for the impact that telehealth can have. And this is just a small sample. Virtually every partner who provided feedback to us had multiple stories to share that were similar to these. And we at Care Compass Network are very proud that we were able to step forward during this very difficult time to help provide some measure of comfort and support to some of the most vulnerable populations in the Southern Tier. Next slide. So on behalf of Dr. Terrace and myself, thank you all for your time and attention. I'd like to thank Katie Cook and the team at AHI for inviting us to speak and allowing us to share the story of our COVID-19 telehealth assistance program. And now I guess, as I understand it, we have a few minutes for questions, if anyone has any questions for Dr. Terrace or myself.
Thank you very much for that presentation. It's interesting because HI rolled out something very similar in April and May of last year. We didn't have quite as many funds, but we were able to support a little over 20 different healthcare organizations in a similar manner, and have had some similar success stories come out of that. So it makes the work completely worth it, because like yourselves, we had to rapidly get this application and funding resource out as soon as possible. We did get a question from Esther Horowitz, who wants to talk offline. Esther, of course, their contact information is here on the slide, but she's collaborating with community-based organizations with no costs involved between the entities to serve residents with a virtual ER that also makes sure it directs back into the community, and they're having great success with that and moving into Central New York. So I'm sure she will be following up with you. And of course, submit your questions in the Q&A or chat. I am looking at both. One question that came in privately was, what was the texting application that was mentioned in this presentation?
Yeah, I don't know exactly which application they were using. I would probably have to dig back into their actual grant application to see which software platform that that family practice was using. I don't know the exact name of the one. I know that it integrated with their phone system. I think they had a voice over IP phone system, and it was maybe a module of the phone system, or I know that it integrated with their office phone system.
Okay, interesting. Yeah, if you happen to come across what that is, you can send me an email and I'll follow up.
Will do.
I'm not seeing any other questions. One individual is interested in learning about the virtual ER, so I will connect that person to Esther. That's separate outside of here. All right, so if there are any other questions, you can throw them in the chat and Q&A. I can compile them to send to Dr. Terrace and Jim. So thank you both very much for your presentation. I'm going to, all right. So we can turn your videos off if you would like. I'm going to turn it over now to some state agency updates, specifically the New York State Department of Health. We have Megan Procorum on the call today, who's going to provide a high-level overview of the Article 7 State of the State Telehealth proposal. So Megan, you can take it away.
Okay, great. Thanks, Katie, and thanks to our presenters today. Earlier this month, Governor Cuomo released a comprehensive telehealth agenda as part of the State of the State. And so I wanted to provide an update on some of the legislative amendments that are included as part of that agenda. And so, so the process will entail, right now, these are just proposals, legislative proposals that are part of Governor Cuomo's budget bill. So right now, that bill is released, and then the state assembly and Senate will release their own bills, and then, you know, the budget will be due by April 1. So right now, the things that I'm going to mention are just in the proposed stages. But notably, the intent is to make permanent some of the COVID telehealth flexibilities. For instance, for Medicaid members, the originating site, so the location of the patient has been, during COVID, the state of emergency, there's no restriction on originating site. So there's a legislative amendment to make that permanent, such that the location of a Medicaid member is not restricted, would be going forward after COVID. Another legislative amendment would be to develop an interstate licensing reciprocity program with states in the entire Northeast region. So this legislative proposal allows the Commissioner of the State Education Department to develop regulations according to education law in consultation with DOH, OMH, OASIS, and OPWDD. So this would mean that practitioners that are licensed by the contiguous states in the Northeast region would be allowed to provide telehealth services if they were not licensed to practice in New York State. So again, this is a proposal that would let SED develop regulations for licensing reciprocity in the Northeast region. There's a couple amendments to insurance law, new sections that would encourage corporations and insurers that their network of providers is adequate to meet the telehealth needs of insured individuals for services covered under their policies when medically appropriate. So that will deal with network adequacy for telehealth and insurance law by insurers. And then there's two proposals that would amend the requirement for healthcare professionals and hospitals on their for their disclosures regarding health plan participation and hospital affiliation. This would be amended to include that they would also need to disclose and indicate if they offered telehealth services. So this is more for patients and consumers to know which providers and hospitals offer telehealth services. And then one of the last legislative proposals is to streamline the patient consent process for the SHINY, the State Health Information Network of New York, to use a single patient consent form with the purpose of increasing interoperability and record access among entities that participate in the SHINY. There's a number of other proposals that are not legislative at this time that would encourage insurers to offer an e-triage or virtual ED platform, as well as to encourage insurers to use or develop e-consult systems. And then we've got a number of other telehealth support programs that have been recommended by the Reimagine New York Commission and two are already underway. One, my colleague from Netric, Andrew Solomon, is going to provide some more exciting information about telehealth training portal. And then the other is a pilot and demonstration facilitator program between AIR NYC and Mount Sinai. And this would be a patient facilitator program that would help really hard to reach communities and patients and and using telehealth equipment and the onboarding and intake process. And we hope to be able to announce some additional telehealth programs through the Reimagine New York Commission in the future. So I'll make sure to keep everyone updated on that. So that is my brief update on the DOH, public health law, and other telehealth law side of things. I don't know if we have time for any questions.
Yes, we have a couple of questions. So there is a question regarding if there are any proposals about hub sites for telehealth or distance sites. Now, my educated guess would be that prior to COVID, distant and hub sites were never an issue anyways. It was kind of free reign, but maybe you can speak to that, Megan, if there are any.
Sure. So prior to COVID, it would depend on the payer in terms of reimbursement for the providers. So the law really goes around what a payer might come to or reimburse to a provider. And so on the New York State Medicaid side, public health law outlines a specific list of individuals or certified individuals that can act as a distant site provider. And so the proposed legislation is to expand that list of eligible providers for Medicaid reimbursement to those that would be part of this interstate licensed telehealth provider program. So if and that would help to address access issues in specific areas and amongst specific specialties. So if there's a more specific question about provider type, I know, amongst the O agencies, OMH and OASAS, they have regulations that authorize different provider types that have been expanded in COVID. And there is, a lot of activity around continuing some of the expansions post-COVID, but the details are yet to be announced.
Okay. On that note of the interstate licensure agreement, do you know which states are anticipated to be in this Northeast region?
I don't have the specific details on which states at this time.
Okay. And the last question that's come in so far is, has there been any word on HCBS or home and community-based services providers in telehealth, that is, providers who are not licensed but are designated to provide home community-based services? That might be an honest question. I don't know if that's a you question.
That's probably not a me question specifically. I might have to get more details on that. So this would be someone working. I think I would need more details on the type of provider.
Okay. Eileen, if you could send me an email with more information on exactly what kind of information you're looking at, I'm going to send you my email right now, and we can follow up with that. Another question came in, what about telephonic services being reimbursed by Medicaid after the emergency order is lifted?
So that's a great question. I'm glad someone asked that. So in last year's budget, there was an amendment, and this is on the books, in public health law, which is the law that pertains to New York State Medicaid, that authorized the Department of Health Commissioner to develop regulations for audio-only telephonic reimbursement for services, but via defined regulations. So, and given the COVID state public health emergency, we've absolutely heard from stakeholders across all of the agencies how essential audio only can be for certain populations and services. So Department of Health is in the process and is very actively engaged in coordinating amongst the other agencies, OMH, OASAS, and OPWDD, to really look at telephonic reimbursement and the development of these regulations. So that activity is actively happening right now. Unfortunately, I can't provide a specific timeline on what may happen, but one thing to be aware of is that reimbursement for audio only is really dependent on federal match participation for reimbursement because for a number of reasons, and there's some technical reasons for all of that as well. So there's been some on the federal level, some legislation that's been proposed to continue audio only. So a large part will depend on some federal action for audio only to determine what the full extent of what can be accomplished on the state level. But absolutely, the state has the authority to develop regulations around telephonic reimbursement, and those regulations are in development at this time.
Excellent. Next question is back to that distance site question. For distance sites, would this expansion relate to federally qualified health centers, allowing them to act as distance sites post-public health emergency? I know for New York State Medicaid, this was allowed prior to the public health emergency if you were opted into APGs, or was it out of APGs? I can't remember, but maybe you can clarify more on that.
Sure. So on the state side for New York State Medicaid, before the COVID-19 pandemic, FQHCs were allowed to serve as a distance site provider. So once the public health emergency ends, that will continue, that policy will continue for FQHCs to act as the distance site for New York State Medicaid members. So that does not necessarily include Medicare or dually eligible individuals.
Right. Okay.
So
no, go ahead.
So for those individuals, we'll have to see if and when there's changes on the federal side on CMS and HRSA. Okay.
Yes, I think we'll have to wait and see what the federal government does before anything else really happens. The next question came in for OMH. Megan works for DOH, so I don't know if she'll be able to answer this. But the question, I'll ask it, is do you know if New York OMH is considering further amendments for telebehavioral health usage at Article 31 facilities? Is there any chance they will drop the approval process? I'm just going to check the attendee list because I know Amy Smith is on. Amy, I'm going to unmute your line if you want to chime in on this really quick, if you're able to.
Can you hear me okay?
Yes.
Okay, great. No, I don't think we have a plan to drop the approval process. We've streamlined it, I think, as much as we can at this point, allowing providers to submit one application or administrative action versus many, but we still want to take a look at policies and procedures, and we want to make sure that we're clear on who's delivering services via telehealth.
Excellent. Thank you so much, Amy.
Sure.
Okay, no other questions have come in for Megan. So Megan, thank you so much for hopping on today. If anybody thinks of anything after the fact, my email is kcook@ahihealth.org. Please reach out to me and I can coordinate with Megan to get a response. Next up on our agenda is an update from the Northeast Telehealth Resource Center. Andrew Solomon has joined us today. He is a project manager with the Northeast Telehealth Resource Center, and he's going to give us a brief update on the newly released New York State Telehealth Training Portal and upcoming telehealth education advisory group as a part of the Reimagine New York Commission. So go ahead, Andrew.
Yeah, thank you so much, Katie. Good afternoon, everybody. As Katie mentioned, I'm with the Northeast Telehealth Resource Center covering all of New York and New England, federally funded through HRSA. We're very excited that we just launched a New York State Telehealth Training Portal in collaboration with DOH and endorsed by the Reimagine New York Commission. I just stuck a link to it in the chat, but it's nytelehealth.netrc.org. It's based on some e-learning infrastructure our parent organization has in place and some work we did back in 2018 with the California Telehealth Resource Center to create a website they called telehealthtrain.org. If you check out the portal, you can register at no cost. It'll be open access through funding through HRSA. Currently, as Megan alluded to, we have an overview presentation available from DOH. We also are beginning to launch a series of telehealth essentials modules, but we're also hoping to work with stakeholders from across the state to continue to build content around sort of special telehealth special topics. So we're actively recruiting folks who are interested in contributing content and collaborating. We look at this as a pilot program. We hope to extend this across the region that we serve into New England. I don't know if that will be sort of one view into a regional portal, or because of the state specifics across the region around telehealth, we may create additional state specific portals as well. There certainly seems to be interest in that. So if folks are interested in learning more, thanks Katie for putting my email there. Would love to hear from you, and definitely check out the portal if you have a minute.
Excellent. Thank you, Andrew. I've been looking through the portal, and it's great that New York was the first state in our region to get something of this value. So I'm very excited about that and excited to see the continued rollout of this. So if any of you have individuals in your practice who are in need of a refresher, or maybe a new hire, add this to the list of training videos or materials that they should go over. All right, looking at the agenda, I just wanted to give a few updates from the North Country Telehealth Partnership. Bob, feel free to chime in if you have anything on your end. I put in the agenda a few upcoming webinars. Of important note is the Center for Connected Health Policy is doing a series of webinars right now. It's a 4-part series. They've done 2 already, and 2 more are scheduled. They are on Fridays at 2 p.m. and there is a significant focus on telehealth and Medicaid. So if you are interested, I highly recommend that you check out those webinars, because the Center for Connected Health Policy is fantastic. And for the individual who asked about slides, we don't have any slides during this portion, but we are recording. Other than that, Bob, did you have any updates for the group? I think you muted yourself.
Nope, I don't. Dates.
Excellent. So right now we are tracking data for the remainder of 2020. And I believe that the next Learning Collaborative will be able to share a little bit more about some trends in 2020 related to COVID. Just at a very high level overview, I can tell you, at least in our region, and we can make this a discussion point for the next call. Would love to hear from other folks around the state if they're seeing the same thing. In terms of overall telehealth data, whether it be telephonic, telemedicine, we are seeing that counseling is by and large the highest number of telehealth related encounters since COVID started, with primary care and substance use disorder services coming in a very distant second and third, but still a significant amount of encounters. So I'd be curious to hear more from all of you when we do our next Learning Collaborative, if that's what you're seeing as well. We're also starting to see numbers trending back up for telehealth. It was decreasing through June, July, and August, and then spiked in September, went down a little bit in October, and November and December, we're seeing some rather dramatic increases across multiple specialties, given the holidays, the cold weather. So I'm not surprised by that data, but we'll talk more in March. The next Learning Collaborative is scheduled for, I'm just looking at my calendar. It will be, I believe, March 15th. Let me just double check that. That is an accurate statement. Yes, it will be March 15th at 2 p.m. And we are, of course, always looking for speakers for the Learning Collaborative. So if you have an interest in presenting about a program initiative that you're a part of, please reach out to me and we can talk offline about that. Hopefully in March, we'll have a little more insight as well into more finalized guidance from our state and federal partners and try to get an understanding of what a post-COVID telehealth landscape might look like. So until March, please stay safe, please stay well. Thank you for joining us today and have a wonderful afternoon. Goodbye.